Okay, class. So we begin now, right? So today we are going to talk about facial bone fractures, right? So before we go deeper into the subject, into the topic, I need to tell you that there are so many bones in the face, right? So in cranial bones, there are a few cranial bones and there are a few facial bones, right? And among all the facial bones, I know, like there is maxilla, there is mandible, there is zygoma, there are nasal bones, I know, inferior turbinate, I know. So ENT surgeon doesn't deal with all the bones, but the patient won't come to you with only the bones that ENT surgeon is concerned with. Right? For example, the patient, the history, the etiology of facial bone fractures is usually physical assault, road traffic accident, falls, like that, right? And in such cases, other parts of the body like the limbs, like the abdomen, chest are involved, and as well as the face is involved, right? The patient may have the fracture of the mandible, the fracture of the maxillary bone, and the fracture of the nose, and other things. Similarly, head injury can also be involved. So usually these cases of RTA, fall, physical assault, right? So they require multidisciplinary treatment. So you need to involve doctors from or surgeons from various specialties, right? So ENT surgeons are one of them. After the patient is made stable, there comes the ENT surgeon, there comes the neurosurgeon, and also there comes the maxillofacial surgeon. So why I'm giving you this overview is, so there is something called maxillofacial surgeon, right? And we are ENT surgeons, right? So you need to know about maxillofacial surgeons because there is a lot of overlap between maxillofacial surgery and ENT surgery. So in the diseases that we learned previously, like epistaxis or polyps or sinusitis, it falls solely in the field of ENT surgery. But the facial bone fractures or the fractures of the facial skeleton, so there are overlap between maxillofacial surgeon and ENT surgeons. So maxillofacial surgeons, they are MDS, Master in Dental Surgery. Right? So they graduate from BDS, not from MBBS. And after BDS, there are again different subjects. And like after MBBS, there is ENT, there is internal medicine, there is surgery, and there is psychiatry, and so many subjects. And similarly, after BDS, there is maxillofacial surgery, periodontics, orthodontics, conservative dentistry, and there are different subjects like that. So maxillofacial surgeons, they have the background of BDS, and many times we need to collaborate with the maxillofacial surgeon for the treatment of facial bone fractures. As an ENT surgeon, we essentially deal with nasal bone fracture, right? So nose is also a part of the facial bone, and so ENT surgeon mostly deals with facial bone fracture. So as MBBS students of ENT, you need to know in detail about the nasal bone fracture because that is very common, and such patients come very frequently to your OPD and the emergency, right? But you also need to know something about the management of other facial bones because you need to know when you need to ask for help from maxillofacial surgeons, right? So so we go into detail of the nasal bone fracture and I'll throw some light on other fractures of the facial bone. Okay, so maxillofacial trauma management. Okay, so like in any emergency case, there should be airway maintenance, control of hemorrhage, and because the etiology is trauma, right? So there are associated injuries like injuries of head, chest, neck, abdomen, cervical, spine, pelvis, limbs, any part of the body. So this should also be taken care of. and similarly wound debridement and treatment of maxillo-facial bone injury. Now first we'll talk about nasal bone fracture, right? So there are different sort of fracture, right? So medium force will cause open book fracture when nasal septum collapses and nasal bones splay out. And greater force will cause the shattering of the nasal bone, spilling of the frontal process of maxilla. Right? So look here, this is the nasal bone, this is the septum, and so medium force it is causing of the spilling out of maxilla, spilling out of nasal bones, and also the frontal process of maxilla. And there is something called ambulated fracture. Okay, ipsilateral nasal bone fracture. Okay, when the patient is like somebody is bounced on the right side of the nose, so there is fracture of the ipsilateral nasal bone, and if there is greater force, then the both nasal bones will be fractured. Now, patient will has a typical injury, you will say of accident or bleeding from the nose, and so you need to look for these clinical features. So what you need to know is nasal bone fracture is essentially a clinical diagnosis. So you can do several radiological investigations, but suspicion of nasal bone fracture and even confirmation can be done easily clinically. So there are a few features that you need to know. So edema over nasal bridge within 3 hours of injury. So as soon as there is nasal bone fracture and the patient presents to you, it will take a while, and after a while there will be edema. There will be swelling of the nasal bridge. Similarly, there will be periorbital ephimosis, and if you palpate over the nose, nasal bridge, there will be tenderness. And similarly, there is nasal bone crepitus. So, do you know what is nasal bone crepitus? So, when the bone has fractured like this or like this, and when you palpate the nasal bone, the broken part will have friction with the other parts, which may be broken or intact. And because of that friction, so you'll feel a crepitus. So, nasal bone crepitus is one of the most diagnostic clinical feature of nasal bone fracture. Right? Similarly, there will be external nasal deformity, and similarly there will be epistaxis, because those fragments of the nasal bone it may cause trauma to the mucosal side of the inside the nasal cavity, and that may result in epistaxis. Similarly, there are some open wounds, and the fragmented bone will make cause the open wound, and there will be the laceration of the nasal skin. So regarding external nasal deformity, so as you know that now we're nearing the end of the classes of the nose, so you know that nasal straight nose or straight nasal septum is more of a rarity than a normality, right? So the patient may have deformity previous to the accident. And because these nasal bone fractures or any traumatic cases, they are usually the medical legal cases. And as we know that it happens, the person who is the victim, the victim, he tries to he tries to get a lot of money, or he makes the culprit to pay for all the conditions, all the problems that he was having even previously. Right? So to rule out if the patient was having any nasal deformity previously, you ask for the photographs before the accident. So this is everybody has a mobile phone, and everyone is taking they're taking selfies. So everybody will have their photo showing the nose before the trauma. So you need to compare. Now the patient had edema, and the edema, it usually subsides after 3 to 5 days. It builds up within 3 hours to 6 hours and subsides after 3 to 5 days. Now this thing has importance. Why do we talk about the subsiding of the edema? Because our management, our treatment is based on one of the factors, and among that edema is one. X-ray. We often do X-ray, though it is not clinically indicated because nasal bone fracture is a clinical diagnosis. So we do X-ray for medical legal purpose, okay, and to show that show it to the patient so that he will be convinced that there is definitely a fracture. And whenever we talk about fracture, the patients, they have a concept that there should be an X-ray. Now, treatment is very important, and you need to know about it. When the patient will require treatment and when he should be referred, right? So fractures without displacement, right? You do the X-ray or you see the patient clinically and there is fracture, but the fracture parts are in the same place, right? We often get the cases of fractures without displacement. So here, we just need to counsel the patient. We need to tell him how the disease is going to progress, right? So nasal bones, they have fractured and they are in a line, right? They are linearly placed. They are not displaced, right? So if the nose is prevented from any further trauma, so after 2 weeks, the healing will occur and there will be the fusion of the bones. So fractures with the displacement requires no treatment. So you treat the patients only who have external nasal deformity, bleeding, and difficulty in breathing. So difficulty in breathing can result from the deviation of the septum or the fracture of the septum. Similarly, nasal bone fracture that are impacted inside the nasal cavity, they can also cause bleeding as well as difficulty in breathing and also deformity. So only if there are symptoms, so you go for aggressive management. So fractures with displacement, like the fractures like this, which are displaced, which are causing deformity, right? Also epistaxis. So there is something called closed reduction. So there is another type called open reduction. So we usually do closed reduction in our setup, right? Open reduction can also be done. So it is rarely required, and it is required when there is infection, when there is comminuted fracture, or when there is failed closed reduction, right? So you attempt the closed reduction, but the results are not very good. So in such cases, you need to do the open reduction. Similarly, there are some patients who present after many days after the trauma, after there is ossification of the bones. So in such cases, closed reduction is not going to help. So you need to do open reduction. So for open reduction, so you need to have an idea about rhinoplasty. Now treatment guidelines. So this is very important for you, right? So if the patient comes to you soon after the accident, so you reduce the fracture instantly, right? But if he presents after a few hours, then the edema will have developed. So make sure that you do not attempt surgical correction or closed reduction after a few hours, after 6 hours of the trauma, because of the edema, there will be a lot of bleeding, and similarly, the fragments of the bone and the nose, it cannot be closed in a perfect manner, right? So what you do is you wait for at least 5 days or up to 7 days until the edema has subsided, and after that you operate the patient. So this is what usually happens, right? So the patient comes after a few hours, 10 hours, 12 hours, or even a few days, right? Because the patient will first go to the hospitals or the clinics in the periphery where they are managed, where the blood investigations are done and other things. So that will take a few hours, and when they come here, so it will already have been more than 6 hours, and the patient would have developed edema. So such cases, you counsel the case, you can send it back to the home and ask him to come after 5 days, or you admit him, right? If there are symptoms like bleeding or difficulty breathing, and after the edema has subsided, you take the patient to the OT, and then you do the closed reduction. So the fracture should be managed within 2 weeks, right, in adults, and in 1 week in children, right? So you do not suggest for closed reduction after 2 weeks because the fracture would have, the bones would have ossified, right? Closed reduction should be done before healing, and heel deformity is corrected by rhinoplasty or septorhinoplasty. So this is what I mean by open rhinoplasty. So suppose the patient comes after 3 weeks. right? So you do not attempt close reduction in this patient. I know you send the patient for open reduction. Now, how is close reduction done? We prefer to do this close reduction under general anesthesia. It can be done under local anesthesia too, but it is a very painful condition, right? So we prefer under general anesthesia, and after induction of general anesthesia, make sure that you do the throat packing so that all the bleeding that occurs and after reduction or during reduction, the gauze piece in the throat pack, it absorbs all those bloods and secretion so that the patient doesn't aspirate, right? So maybe this patient had a blow injury from this side, and this side of the bone is injured, and so is the septum, right? This is non-depressed bone. So what we do is, first this should be elevated, and then the septum should be corrected, and after that, if you the alignments need to be seen, right? You need to look from different angles. You need to look from downwards, from the board side, right? From above, from all the angles, and see if it is straight like this, right? And after that, we put on some covering, right? Okay, so after the fracture, it may happen like this. So what you need to do is, first you need to out fracture, right? And make it straight, right? You need to make a proper alignment, right? And after the proper alignment is restored, then you do the nasal packing for the support, and you also give some external support. Okay, so so here we are talking about two instruments, Walsham forceps and Asch forceps, right? Okay, so these instruments, they are important for your OSCE examination, right? You will have 15 OSCE questions for your OSCE. So these instruments may be asked, maybe shown in your slide, and then you'll have to answer. So what is Asch forceps, or what is Walsham forceps, and what are their functions, right? So there is just one Asch forceps, right? So this is for the septum, and this is for the nasal bone, right? So because there are two nasal bones, right side and left side, so you need two Walsham forceps. And look here, this is how the impacted bone is brought into correct alignment. And here the right side, the right bone. So it is brought into correct alignment. And then there is Asch forceps. Using this, the septum is brought in proper alignment, right? As MBBS students, you do not have to do this, but these two instruments and the management protocol is quite important, right? And after it is all brought in alignment, right? So you need to support the nose so that the patient is protected from further trauma or trauma that may otherwise sleeping or even minuscule injuries, right? So this is plaster of Paris, right? So this is a splint, and this is plaster of Paris. So splints are, they are more cosmetic and they are easier to apply. But if splints are not available, then what we do is we make a few layers of plaster of Paris and cut it in this manner, right? And we put it here so that the patient is safe from other injuries. Now, probably this patient presented late to the ENT, and there is deformity. It has been there for a long time, and rhinoplasty should be done in such cases, right? So that was all about nasal bone fracture, right? So that is what ENT surgeon must deal and must manage, right? And you need to know when to refer the case. And now the following fractures, these are the fractures that are usually dealt by maxillo-facial surgeons. And when the case comes to you, it won't be an absolute or a sporadic case of nasal bone fracture. Usually, when there is physical assault, punch, or fall, only the nasal bone will do fracture. But most of the time, especially in the RTA and other serious falls, so leaf foot fractures are commonly seen with nasal bone fractures. So leaf foot fractures, these are the field of maxillo-facial surgeons. So let us have some overview about this, right? So there are three types of leaf foot fractures, right? Leaf foot 1, leaf foot 2, and leaf foot 3. So look at these lines, and these lines describe when it is Lefort 1, Lefort 2, and Lefort 3, right? So Lefort 1 is transverse, Lefort 2 is pyramidal, and it is Lefort 3 is craniofacial disjunction. When we go from 1 to 3, the severity of the fracture increases. So now the definition: it runs above nasal floor through the nasal septum, maxillary sinus, and inferior parts of the pterygoid plates. So this is Lefort, right? Lefort 1. Lefort 2 runs obliquely from maxillary sinus floor to infraorbital margin, across orbital floor and lacrimal bowl to nasal. Lefort 3 runs from medial orbit wall to superior orbital fissure across the sphenoid and zygomatic bone to zygomatic frontal suture and inferior to pterygoid plates. So this diagnosis is made not clinically but after seeing the CT scan, right? So if a patient has Lefort injury, right, the radiologist will have mentioned Lefort 1, Lefort 2, Lefort 3, right? Now fracture reduction, right? So just some basics, right? Clues methods: hard palate, dis-impaction with Asch Forceps, external fixation, halo frame or box frame, and inter-maxillary fixation. I just see the fractures, right? It's the fractures, and this should be kept in place. Right? And there are open methods like inter-osseous wiring and compression plates and screws. Right? Hard plate is impacted, and then external fixation is applied. Right? So these are done by Maxillo-facial surgeon. As an ENT surgeon, I have never done this, and I have not been trained to do this as well. But I need to know when I need to send this patient to Maxillo-facial, or when I need to ask the Maxillo-facial surgeon to come to see my patient. Right? And this is inter-maxillary fixation. Right? Inter-osseous wiring. Right? This is so much like orthopedics. Right? And they also use the plates and screws, right, to hold the fracture and different bony parts. And similar blowout fracture, right, of the orbit. So this is important, and you need to be able to diagnose it, right? So medium strength blunt trauma to the ball, usually in sports injury or physical assault. Now clinical features: ophthalmos, orbital emphysema, inferior rectus and orbital tissue gets trapped in fracture site, prevents upward movement of eye, diplopia, orbital hemorrhage, ruptured eyeball. Right? So you need to know about the disease, because sometimes there are some medical officers who are very enthusiastic and who feel like managing cases on their own, and that is a good thing. That should be encouraged. Right? We encourage, like suppose you are posted in a very remote area, which is around 1 hour or 1 day's walk from the center, right? So if you are enthusiastic and if you think you are able to manage that, then so it's fine. You should do that, so that the patient will save a lot of money and save a lot of time. Just give me a second. Right? So in this case, so you just see that externally, you cannot see so many things. There may not be a lot of symptoms, or clinical features, but the damage may have been internal. So there are a few signs that you need to look for, so that you can suspect other severe injuries, and so that you could know that the patient should be referred to a higher center, right? So prevention of the upward eye movement, diplopia, orbital hemorrhage, ruptured eyeball, and you can see this. So also look for the movement of the eyeball. So whenever you are looking in the emergency, so you look for the normal functions. Are they preserved or are they compromised? So such patients, any facial skeletal fracture, whenever there is injury on the face, so sometimes, most of the time, it is easy for you to separate or categorize it as a superficial, or it is only skin deep injuries. In such cases, you do not need to do aggressive management. But the face, in face there are so many bones and they are very fragile and they are very small, right? And they can easily break, right? Some bones, they are just like small thin plates, right? So CT scan, whenever even there is little suspicion, always go for CT scan. CT scan of the paranasal sinuses. Usually the traumatic patients, they are ordered for CT scan of the head or CT scan of brain. So along with brain, you also go for the CT scan of the paranasal sinus. All of these areas will be taken in CT scan of PNS so that you can diagnose even small injuries or even the fractures that are not displaced. Right? The good thing is, right, in emergency cases, it is better to overdiagnose the patient than underdiagnose. Right? You do not want to miss a case because you did not send for CT scan. And remember, most of the cases are medical legal cases, right? And because of delayed diagnosis or no diagnosis done at your center, suppose there was a fracture which you did not diagnose, you thought that okay, you counsel the patient that okay, it is nothing, okay, it is a superficial injury and the patient can be managed at my center. You keep the patient for a few days, but then the patient went to the other hospitals. He got referred or he got discharged on request. And when he goes there and he undergoes a CT scan and there are bones. So you may be implicated in such cases, right? So make sure, even when there is little trauma in the face, with little suspicion, go for CT scan of PNS, right? So this is what we understand by teardrop sign, right? The orbital content, usually the periorbital fat, right? It has come into the maxillary sinus like this. Treatment procedure, right? Release of entrapped orbital soft tissue and inferior rectus muscle, removal of small bony fragments and depositing of large bony fragments, repair of bony defect with microplating and biocompatible implants. Okay. So look here, there is defect, right? And so implant has been kept and it is repaired so that the orbit or the orbital fat doesn't prolapse. Zygomatic bone fracture, right? So this is another fracture that is quite common. So there is something called tripod fracture, right? So look here, this is the zygomatico-frontal suture, zygomatico-temporal, and infraorbital, zygomatico-infraorbital, right? So this is the zygomatic bone. Internal fixation. So you find this all on CT. CT scan is a very important examination in facial bone injury, facial or any facial injury, right? Okay. Okay, tile creep reduction. So whenever there is fraction, you reduce it, right? And after that, you can do some sort of you reduce it and then you do the fixation, right? Fixation. So you can see here there are the plates, right? Sorry, yes. Okay, sorry. Okay, now I have unmuted, right? Okay, thank you for informing. So this is about Gillie's approach, right? So this is done to manage the fracture of the zygomatic bone, right? So the take home message is, so I have shown you so many drawings, and so many conditions. The take home message is, whenever there is a suspicion, always go for CT scan. Only the CT scan will show you the trauma. Externally there may not be any injury, right? And an ENT surgeon, so in your exam you'll be asked questions. You'll definitely be asked questions about nasal wound fracture, because that is very common, right? And you need to know how to manage, when to manage. So there are some cases of undisplaced nasal wound fracture that may not require referral to higher center. So why ask the patient? Okay, like earlier, the patient from Karnali used to go to Nepalganj for any major injuries. But if there is a nasal wound fracture, and if it requires only the conservative management, so you can do it at your own center. You need to know that. So this is how Gillie's approach is done. So even I have only known it theoretically. As an ENT surgeon, I do not need to do it. Right? Okay, then you do not need to know in detail about this. Right? Okay, so let us come to the mandible fracture. Right? So mandible fractures are very common. Right? And occasionally we get calls from the medical officers in the emergency. And they said that, okay, the patient in the X-ray or the CT scan, the report is that the patient is having mandible fracture. So please come and see the patient. So the mandible fracture, they are not taken care by the ENT surgeon, right? So they are taken care by the maxillo-facial surgeons. But there is something called the mandibular dislocation, right? So ENT surgeon usually deals with that. So this is the mandible. So fracture at the symphysis, fracture in the body, and in the coronoid process, the condylar process, right, and subcondylar area, and the ramus at the angle and the body. So fracture can occur mostly at these sites, right? So this is the epidemiology, right? So the commonest is the condylar process, and so the angle and the body, right? So what are the clinical features, right? There is trismus, malocclusion of teeth, right? So malocclusion means when you occlude, it is not proper, right? Ecchymosis of oral mucosa, tenderness at the site of fracture, and because there is a fracture, there will be crepitus. Step bony deformation palpation. So when you palpate, so there is a change, change in the normal contour of the bone. And look here, so X-ray has been done, lateral oblique X-ray, and you can see the fracture here. This is the hard bone, right? This is the lateral view. And this is OPG, Orthopantomogram, right? This is one of the most very important investigation in dental. Now fracture reduction, right? Just like any other fracture of the facial bone, right? Interdental wiring, right? Arch bars and rubber bands, open methods, inter-osseous wiring, and lag screws, compression plate and screws. Right? So the method is mostly the same. Right? The fracture should be reduced and it should be brought closer so that the ossification of the bone takes place. Right? Interdental wiring, arch bars and rubber bands, inter-osseous wiring. Right? Look at the mandible. Right? The wiring has been done. So depending on the site of injury, right, and the instruments available, the surgeon, the maxillo-facial surgeon chooses the method to treat. Right? And the lag screw, you can see there is the screw here, and the screw has been fixed on the fracture, and the bone will heal. And just like the braces, the braces are going to rack it outside of a deformity over the line. Right? So similarly, using screws, wires, and all other things, the mandibular fracture is restored. And these are the compression plates, right? Okay, the compression plates intraoperatively, right? So, okay, again, these are the compression plates. Okay, so that's all for today, right?